welcome to the deep dive. You sent us a really interesting set of materials this time, and we've been digging in.
Yeah, it's fascinating stuff.
Today we're tackling the ICD-10-CM coding guidelines.
Yeah.
Think of this as maybe your cheat sheet to understanding how medical diagnoses get turned into a code and why that matters for the bigger picture of healthcare data.
Exactly. You provided us with key sections from the official guidelines, plus a helpful quiz and glossary, too.
Right.
Our goal is to, cut through some of that complexity and show you the logic behind these codes and why they're so fundamental in the medical world.
Okay, let's unpack this then. The guidelines start with the structure of the ICD-10-CM codebook. We've got the alphabetic index and the tabular list.
Yep.
It sounds simple enough, maybe, but why the two-part system? Is there a specific reason?
Well, what's fascinating here is how these two parts really have to work together for accuracy.
Okay.
The alphabetic index, that's your starting point. It's an alphabetical list of medical terms that points you towards a potential code.
Right, like a regular index?
Kind of, yeah. But that's just the first step. The tabular list is a structured numerical list organized by body, system, and condition. It gives you the full code and, crucially, essential details like definitions and rules.
Ah, okay.
You absolutely need both to make sure you've got it right. Think of it maybe like looking up a word in a dictionary. The index gets you close, but you need the full entry for the definition and usage.
So the alphabetic index is the quick route, the starting point, and the tabular list is where we double-check and get the full picture. That makes sense.
Nicely.
Now, these codes themselves have a specific format, right? Category, subcategories, and then the codes themselves ranging in length.
Precisely. Codes can be 3 to 7 characters long. The first 3 characters are the category, giving you the broad type of condition.
Okay.
Subcategories add more detail with 4 or 5 characters. The full 7-character code provides the highest level of specificity. And here's a really key point. If a code needs a 7th character, you must include it. It's like a phone number,
Yeah.
You need all the digits to connect properly. It's not optional.
And what about this X character? It popped up in the materials?
Yeah.
Sounds a bit mysterious.
The X is actually quite clever. It's a placeholder.
A placeholder? For what?
For future expansion, basically. Sometimes a code will eventually need a 7th character, but doesn't have enough characters in between right now. The X fills those spots, so the 7th character ends up in the correct position, keeping the code structure valid.
I see.
It's like leaving blank lines in a notebook for future notes without messing up your current numbering.
Got it, like keeping space for things to get more detailed later. We also saw some abbreviations, NEC and NS. I imagine these are pretty common in medical notes.
They are very common. NEC stands for Not Elsewhere Classifiable.
Okay.
This means the documentation is pretty specific about the condition, but there isn't a precise code for it within that specific category. So it gets grouped into an other specified code.
Right. NOS, on the other hand, means not otherwise specified. This tells us the documentation lacks the detail to assign a more specific code, so we have to use the unspecified option.
So NEC's like, we know what it is, but the system doesn't have a perfect spot, and NO is, we need more info to be precise.
That's a great way to put it. Yeah.
That's helpful. And it's not just letters and numbers, is it? Punctuation like brackets, parentheses, and colons has a role too. It's like a mini grammar for codes.
Exactly. Think of the punctuation in ICD-10-CM like a secret language within the codes, each mark providing crucial context.
Okay.
Brackets offer synonyms or explanations, parentheses add extra non-essential details. Things that don't affect the code choice.
Right, like nice to know info.
Kind of. And colons signal incomplete terms that need more information from one of the indented entries that follow to be a valid entry. Mastering these nuances ensures accurate interpretation.
Okay, so they're like little signposts in the codebook. What about terms like and with, or in? Do they mean exactly what we'd expect in everyday language? Not always. In ICD-10-CM, an and in a code title should be read as and/or.
Oh, okay. More inclusive.
Yeah. And with and in usually mean associated with or due to, often suggesting a cause and effect relationship.
So like diabetes with neuropathy.
Exactly. It's generally assumed to mean the neuropathy is caused by the diabetes, unless the documentation specifically says otherwise.
That's an important assumption to keep in mind. It's not always a direct link in reality, I suppose.
No, but for coding, that's the default interpretation.
Now, what about C and C also references? Sounds like they're directing you to look somewhere else.
Precisely. A C reference is a direct instruction. It says, the term you looked up isn't a valid starting point, go to this other term instead. It's a redirect.
Mandatory redirect.
Right. A C also is more of a helpful suggestion. It points you to another term that might have useful information, especially if you haven't found exactly what you need under your first search.
So C is mandatory, C also is a helpful nudge. Got it. Then there are code also notes. Do they tell you which code should come first?
Code also notes are like saying, hey, there's another important piece to this puzzle. They indicate that 2 codes may be required to fully describe the patient's condition.
Okay.
However, they don't tell you which one goes first. That depends on the specifics of the medical situation and other coding rules, like the reason for the encounter.
And what about default codes? What are they defaulting to?
Default codes are designed to represent either the most common version of a condition within a category or the unspecified form of that condition. They're used when the medical record doesn't give enough detail for a more specific code. It's the fallback.
Makes sense. It's the go-to when information is limited.
Yeah.
Now we have includes notes, inclusion terms, and excludes notes. Let's break those down. Sounds like a lot of notes.
There are quite a few. Includes notes give you definitions or examples of what's covered within a specific code or category. Very helpful for understanding the scope.
Okay.
Inclusion terms are even more direct. They list specific conditions or synonyms that fall under that particular code. Excludes notes are crucial for knowing what not to code together. Excludes 1 is a strict never the twain shall meet rule.
Meaning you absolutely cannot code those two together.
Correct. These 2 conditions are considered mutually exclusive for coding purposes. Excludes 2 is more like these things aren't automatically included, but if the patient truly has both conditions, you can code for both. They aren't part of the same condition, but they can coexist.
Those excludes notes sound vital for avoiding mistakes. Okay. Now there's also this etiology manifestation convention with use additional code and code first. This sounds like it's about cause and effect.
It is, exactly. The etiology manifestation convention links an underlying cause, the etiology, with a resulting condition, the manifestation.
Right.
The guideline says you code the cause first, then the effect. A use additional code note at the etiology code tells you to add the manifestation code second.
Good.
Conversely, a code first note at the manifestation code directs you to code the underlying cause before it. Often, manifestation codes will say, in diseases classified elsewhere, in their title, and they can never be the main or first listed diagnosis.
So it's like saying code the root problem and then code what that problem led to. That makes logical sense. Finally, in this overview part, it's emphasized that only the actual codes are used for reporting, not just the general categories.
That's right.
And it's based on what the doctor documents as the diagnosis, not necessarily every single test result underpinning it.
That's right. You have to code to the most specific level available in the classification. And yes, coding relies heavily on the provider's diagnostic statement. Their professional opinion that a condition exists is generally sufficient for coding purposes. You don't necessarily need to see all the supporting lab work explicitly mentioned unless the guidelines specifically say so for certain conditions.
Okay, now that we have a good grasp of the structure, let's talk about actually finding the right code. The guidelines really stress this 2-step process. Alphabetic index first, then tabular list. They keep repeating that.
For good reason. As we said, the alphabetic index gets you started, but it often doesn't give you the complete code.
Right.
A dash at the end of an entry in the index is a big visual cue that you need to go to the tabular list for the rest of the characters.
Ah, that dash is important.
Very. And it's not just about finishing the code. The tabular list has those all-important notes and rules. Includes, excludes, code first, use additional code that could actually change which code is correct. Skipping this step is, well, a recipe for errors.
So even if the index looks like it gives you a full code, you always have to double-check in the tabular list.
Always, no exceptions.
Got it. Now, in the tabular list, codes can be 3 to 7 characters long. The rule is to code to the highest level of specificity documented. What does that mean in practice?
It means if there's a more detailed code available for the condition the doctor has written down, you have to use that more detailed code.
You can't just stop early.
Exactly. You can't stop at a more general, say, 3 or 4 character code if a more precise 5, 6, or 7 character code exists that matches the documentation.
Yep.
And as we mentioned, if a code requires a certain number of characters, like that 7th character, it's just not a valid code if you don't go to the full length required.
Right.
You can only use a 3-character code if that category isn't broken down further, if it's not subdivided in the tabular list.
So more characters usually mean more detail,
Ah.
and you should always aim for the most detail the documentation supports.
Yeah.
Makes sense for data accuracy.
Definitely.
Now, who is allowed to actually document diagnoses for coding? It's mainly the treating provider, but there are exceptions listed.
Exactly. The primary responsibility is with the physician or other qualified healthcare professional who is legally accountable for establishing the diagnosis, the one treating the patient.
Okay.
However, there are specific things that other clinicians involved in the patient's care can document for coding purposes, which is helpful.
What?
These include things like body mass index, BMI, the depth and stage of certain ulcers like pressure ulcers, coma scale scores, the NIH stroke scale score.
Ah, things often assessed by nurses or specialists.
Right. Also, social determinants of health, things like housing status, economic issues, laterality, left versus right side, and under-immunization status. This helps get a fuller picture without requiring the main physician to document every single one of those details themselves.
Okay, so it's about using the expertise of the whole healthcare team efficiently. Let's talk about some special coding situations. First, signs and symptoms. When is it okay to code them if we're aiming for a definite diagnosis?
Well, coding signs and symptoms is perfectly fine and often necessary when you don't have a confirmed diagnosis by the end of the encounter.
Right, that's all you know for sure.
Exactly. You should also code any other significant signs and symptoms that aren't typically part of a confirmed diagnosis that you do have.
So if it's an unusual symptom for that disease.
Precisely. But you shouldn't code symptoms that are just a routine part of the illness that's already been diagnosed. For instance, if someone has pneumonia, you wouldn't typically also code cough unless it was unusually severe or needed separate evaluation and treatment.
That makes sense. No need to double code the obvious. What about multiple and combination coding? Sometimes one code isn't enough, or sometimes one code covers multiple things.
Precisely. Some conditions really need more than one code to fully describe what's going on. This is often flagged by those use additional code or code first notes we talked about, especially with those etiology manifestation pairs.
Yeah.
Combination codes, on the other hand, are single codes that describe 2 diagnoses together, or maybe a diagnosis with a common associated symptom or complication.
So one code covers 2 things.
Right. And you should use a combination code whenever it fully identifies all the conditions present rather than coding them separately. It's generally more efficient and considered more accurate when available.
So it's about using the most accurate code or combination of codes to tell the whole story efficiently. What if a condition is both acute and chronic? How do we handle that?
When a condition is documented as both acute, meaning sudden onset, short course, and chronic, long-lasting, you generally code both.
Both. Which one first?
The guideline says you should list the acute code first, as that's often the main reason for the current visit or treatment focus.
Okay, acute takes priority in sequencing. Now, sequela, that's a term we hear in medicine. In coding, it refers to the late effects of an illness or injury. How do we code those?
Sequela, or late effects, are the conditions that remain or arise sometime after the initial illness or injury has resolved. Think of like a scar from a burn or paralysis after a stroke.
Right, the long-term consequence.
Exactly. Coding a sequela usually involves 2 codes. First, you code the nature of the sequela itself, the scar, the pain, the paralysis.
Okay.
Then you use a specific sequela code, often the original injury code with a special 7th character S, to indicate that this condition is a late effect of that previous condition.
And you don't use the original code.
It's really important not to use the code for the original acute condition at the same time as the sequela code for that same condition. You're coding the result, not the original event happening now.
So you're coding the long-term result and linking it back to what caused it without implying the original problem is still active. What about impending or threatened conditions? Like someone at high risk for a heart attack but hasn't had one yet.
Yeah, how you code those depends on whether the condition actually occurred during the encounter or not.
Okay.
If it did end up happening, you code it as a confirmed condition. If it didn't happen, you need to check the alphabetic index under the main term and look for a sub-entry for impending or threatened.
And if there's a specific code?
If there's a specific sub-entry in code, you use that. If not, the guideline tells you to code the underlying condition or symptoms that are causing the concern or risk, rather than the threatened condition itself.
So code what is or has happened, or the underlying risk if the threatened event didn't occur, and there's no specific threat code. Let's move to some practical coding rules. Reporting the same code, can you ever do that more than once per encounter?
No, the guideline is clear on this. Each unique ICD-10-CM code can only be reported once for a single encounter.
Even if the condition affects, say, both legs?
Right. Even if someone has the same condition affecting multiple parts of their body, you wouldn't just repeat the same single-sided code. You'd typically look for a code that specifies bilateral or use separate codes for each distinct site if available.
What about laterality, left versus right versus bilateral? How does coding handle that?
Many codes in ICD-10-CM have built-in specificity for laterality, identifying if a condition affects the left side, the right side, or both sides bilateral.
Okay.
If a bilateral code exists for a condition that is documented as bilateral, you should use that single bilateral code.
And if there isn't one?
If there isn't a specific bilateral code, the guideline says to use separate codes for the left and right sides if both are affected.
What if the doctor doesn't say which side?
If the side isn't documented, you have to use the code for the unspecified side. And there's another scenario. If one side has been treated previously, say an amputation, you'd use the code for the remaining affected side if the condition is still present there.
So code what's currently happening and be as specific about the side as possible based on the documentation.
Exactly.
What about a borderline diagnosis? That sounds a bit vague. How do you code borderline?
For borderline diagnoses, the guideline says you should code the condition as confirmed unless the classification itself provides a specific entry for borderline for that condition.
So treat it as confirmed usually.
Yes, unless there's a specific borderline code available. Interestingly, this rule applies the same way whether the patient is inpatient or outpatient.
Okay, treat it as confirmed unless there's a specific borderline category. Finally in this section, unspecified or symptom codes, when are they okay to use, given we want to be as specific as possible?
Unspecified codes and symptom codes are definitely okay to use when they accurately reflect the level of diagnostic certainty at the time of coding.
So if that's all the doctor knows.
Right. Use them when a definitive diagnosis hasn't been established or confirmed by the end of the encounter. The key is to code to the highest level of certainty that's known for that encounter, even if that means using an unspecified code, because that's all the information you have available from the documentation.
Makes sense. You can only code to the detail provided.
Now, the guidelines have a specific section on the aftermath of a hurricane. Given recent events, that feels very relevant.
It is, and it shows how coding adapts to real-world events. For injuries directly caused by a hurricane, the guideline prioritizes external cause codes that specifically identify the hurricane.
So there are specific hurricane codes.
Yes. The usual sequencing order is first the code for the injury itself, then the specific hurricane external cause code, and then any other relevant external cause codes like place of occurrence.
There are specific codes in the X37.zoo range for direct hurricane injuries, and these need the right 7th character to show if it's the initial encounter, a subsequent one, or a sequela.
And beyond the immediate injuries, there are also Z-codes mentioned that can describe situations arising from a hurricane, like homelessness or difficulty getting medical care.
Exactly. These Z-codes in categories like Z59, which deals with housing and economic circumstances, and Z75, problems related to medical facilities and other healthcare, help capture the wider impact.
Examples.
Things like homelessness, Z59.0, inadequate housing, Z59.1, extreme poverty, Z59.5, needing but being unable to get into a facility, Z75.1, healthcare facilities being unavailable, Z75.3, help agencies being unavailable, Z75.4, issues with child health supervision, Z76.2, and even ventilator dependence due to power outages, Z99.1.
Wow.
These codes give a much more complete picture of the healthcare needs and social challenges after such events.
That's a really insightful way that coding can track the broader consequences of a disaster, not just the broken bones.
Absolutely. It's crucial for resource planning and public health response.
Now let's look at some specific chapters, starting with Chapter 1, Infectious and Parasitic Diseases. HIV coding seems to have its own very distinct set of rules.
It certainly does. For HIV, a key point is that only confirmed cases are coded.
Confirmed how?
Labs. Actually, a provider's diagnostic statement that the patient is HIV positive is sufficient. You don't necessarily need specific positive lab results documented in the record for coding purposes.
Okay.
If someone is admitted for an HIV-related illness, the principal or main diagnosis should generally be B20, which is the code for HIV disease. Then you'd code any specific HIV-related conditions as additional diagnoses.
B20 first. Any exceptions?
A key exception mentioned is hemolytic uremic syndrome associated with HIV. In that case, D59.31 for HUS is coded first, then B20.
Got it. What about people who are positive but not sick?
For patients who are HIV positive but have no symptoms and haven't had any defining HIV illnesses, the code is Z21, asymptomatic HIV infection status. But crucially, Z21 should never be used if the term AIDS or HIV disease is used, or if the patient has ever had any HIV-related illnesses in the past. Once they've had an HIV-related illness, it's always B20 for future encounters related to HIV.
So B20 is for when they're sick due to HIV or have been in the past, and Z21 is for when they know they're positive but aren't currently ill from it and never have been.
That's a good summary.
What if the test results are unclear or they have a history of HIV illness?
For inconclusive or unclear HIV test results, you'd use code R75. If a patient has a known history of an HIV illness, as I said, you always use B20 for any future encounters, not R75 or Z21.
Right.
There are also specific rules for HIV in pregnancy, code 098.7 first, then B20, and any specific HIV-related illnesses. For HIV testing itself, Z11.4 for screening, plus any sign-symptom codes if applicable. For encounters just for managing HIV medications, B20 plus Z79.899 for long-term antiretroviral therapy. And for HIV prevention, like PrI-PP, Z29.81.
It sounds like a fairly comprehensive set of guidelines for different HIV scenarios. Let's move to sepsis, severe sepsis, and septic shock. This seems like a critical area with potentially complex coding.
It is, and accuracy here is vital. For general sepsis, the first step is to code the underlying systemic infection.
The infection that caused the sepsis.
Exactly. If the specific germ isn't identified, you use A41.9 for unspecified sepsis. And it's important not to use R65.2, severe sepsis without septic shock, unless the documentation explicitly mentions severe sepsis or links acute organ dysfunction to the sepsis.
So just having sepsis and organ failure isn't enough.
The link needs to be documented, or the term severe sepsis used. Also remember, negative blood cultures don't rule out sepsis clinically or for coding, and urosepsis isn't a specific term you'd need the provider to clarify if it's sepsis from a UTI or just a UTI.
Okay, so how do you code severe sepsis?
Severe sepsis requires a minimum of 2 codes. First, the code for the underlying systemic infection, followed by a code from subcategory R65.2, severe sepsis. Then you'd add codes for the specific acute organ dysfunctions.
Infection, then R65.2, then the organs.
Right. Septic shock is even more serious. You still code the underlying infection first. Then you code either R65.21, severe sepsis with septic shock, or if it's post-procedural septic shock, T81.12. After that, you add codes for any associated acute organ dysfunction.
Infection, then the shock code, then organs.
Yes, and importantly, the severe sepsis code, R65.2 or R65.21, or the post-procedural septic shock code, T81.12, can never be the principal or first listed diagnosis. The underlying infection is always primary.
That seems like a key rule. Infection first. What if the sepsis starts during a hospital stay for something else?
The sequencing depends on the circumstances, but generally, if sepsis develops during an encounter for something else and meets the definition of principal diagnosis, you'd still sequence the underlying infection first, followed by R65.2 if it becomes severe. There are also specific rules for sepsis associated with a localized infection. Code the systemic infection first, then the local one. Sepsis after a procedure, using codes like T81.41, T81.44 for infection following a procedure, or 086.00, 86.04 for infection following delivery abortion to identify the site, then the sepsis code. And sepsis that occurs due to a non-infectious condition, code the non-infectious condition first, then the resulting infection.
Wow, lots of scenarios.
And only one code from the R65 category, either R65.1 for non-infectious SIRS or R65.2 for severe sepsis, should be used per encounter. There are also special considerations for sepsis in pregnant women, newborns using P36, and with hemolytic uremic syndrome.
It's very detailed, and the order of the codes is clearly critical for reflecting the situation accurately.
Absolutely. The complex coding for sepsis really highlights the critical distinction between the infection itself and the body's systemic response, emphasizing the need for precise documentation of organ dysfunction to accurately reflect the severity.
What about MRSA conditions? Given the concern about antibiotic resistance, I'm sure there are specific coding rules there too.
Yes, there are. If an infection has a specific combination code that includes MRSA, like A41.02 for methicillin-resistant Staphylococcus aureus sepsis, you use only that combination code.
Don't add anything else.
Right. Don't add B95.62, MRSA as the cause of disease is classified elsewhere, or Z16.01, resistance to penicillin. The combination code covers it all.
Okay. What if there isn't a combo code?
For other MRSA infections that don't have a specific combination code, you code the condition itself first, and then you add B95.62 to identify the MRSA organism. Again, don't use Z16.11 resistance in these cases just because it's MRSA.
Got it. D95.62 is for identifying the bug, not resistance itself.
Exactly. It's also important to distinguish between someone being an MRSA carrier, colonization, versus having an active MRSA infection. Colonization is coded Z22.322 for MRSA and Z22.321 for MSSA, methicillin susceptible Staph aureus.
Can you have both?
Yes, you can actually code both colonization and an active infection if both are documented as being present.
So combination codes are preferred when available, and you need to be careful when to use B95.62 versus Z16.11. Finally, in Chapter 1, COVID-19 coding has obviously been a huge focus recently.
Absolutely. For COVID-19, the main rule is you only code confirmed cases using U07.1.
Confirmed by a test or doctor's note.
Either. Provider documentation that it's confirmed or a positive test result is sufficient. For suspected, possible, probable, or inconclusive cases, you don't use U07.1. Instead, you code the specific signs or symptoms the patient has.
Okay, U07.1 only for confirmed. How is it sequenced?
Usually, U07.1 is the principal or first listed diagnosis, followed by codes for any associated manifestations or resulting conditions.
Always first.
Generally, yes, but there are exceptions. For instance, in obstetrics, pregnancy codes first, sepsis underlying infection first if sepsis is due to COVID, and certain transplant complications.
Right. What about things like COVID pneumonia?
For respiratory issues like COVID pneumonia, bronchitis, lower respiratory infection, or acute respiratory distress syndrome, ARDS, you code U07.1 first, followed by the specific J code for that respiratory condition, like J12.82 for COVID-19 pneumonia.
Makes sense. U07.1 plus the specific manifestation.
Exactly. Other COVID-19 coding covers non-respiratory manifestations, exposure to COVID-19, Z20.822, screening for COVID-19, Z11.52, coding symptoms if COVID is suspected but ruled out. Coding U07.1 if someone tests positive but is asymptomatic, coding a personal history of COVID-19, Z86.16 after they've recovered.
Okay.
Coding follow-up care after COVID, Z09 plus Z86.16, antibody testing, Z1.84, multisystem inflammatory syndrome, MIS, Z28.310 for unvaccinated, Z28.311 for partially vaccinated, Z28.39 for other under-immunized status.
It's clear the coding system has had to adapt very specifically to the nuances of the COVID-19 pandemic.
Definitely. It's constantly evolving.
Let's move to Chapter 2. Neoplasms. Coding cancer seems like another very detailed area.
It is extremely detailed. Key things to consider right off the bat are whether the tumor is benign, non-cancerous, in situ, localized, hasn't spread, malignant cancerous, or of uncertain histologic behavior.
Right.
For malignant tumors, you also need to know the primary site where it started and if there are any secondary or metastatic sites where it has spread.
Okay.
There are specific rules for coding tumors that overlap adjacent sites using a specific 0.8 subcategory code versus multiple separate tumors in the same organ system using separate codes for each. And malignant tumors found in ectopic tissue, like thyroid tissue in the neck outside the thyroid gland, are coded based on where that tissue originated.
Interesting. How do you find the codes?
When looking up codes, you usually start with the neoplasm table in the alphabetic index. It's organized alphabetically by site. If a specific histological type of tumor is mentioned, like adenocarcinoma or squamous cell carcinoma, you look that term up first in the main alphabetic index. And then, critically, you always verify the code you found in the tabular list to check for notes and specificity.
Always back to the tabular line.
Always.
And when someone is admitted or seen for treatment of a tumor, how do we decide the main diagnosis, the principal diagnosis?
It generally depends on the focus of the encounter. If the treatment is primarily directed at the main primary tumor site, then that primary malignancy is usually the principal diagnosis.
Usually.
Well, a major exception is if the primary reason for the encounter is specifically for chemotherapy, immunotherapy, or radiation therapy administration. In those cases, the Z51 code for the therapy session should come first, followed by the malignancy code.
Okay, therapy first in that case. What if they're treating a metastasis?
If only a secondary or metastatic site is being treated during that encounter, then that secondary neoplasm becomes the principal diagnosis.
Makes sense. What about complications?
Ugh.
Anemia.
For complications like anemia due to the cancer itself, you usually code the malignancy first, then the anemia code, specifically D63.0, anemia in neoplastic disease.
Cancer first, then anemia.
But if the anemia is caused by the treatment, the chemo, immunotherapy, or radiation, the order flips.
How so?
Then you code the anemia first, then the neoplasm, and then the code for the adverse effect of the drug, like T45.1x5 for chemoimmuno, or the radiation, Y84.2.
Okay, that order matters.
Yes. Similar specific rules apply for dehydration due to malignancy, dehydration first, then malignancy, and for complications arising from surgical treatment of the cancer. The complication is sequenced first.
What if the original tumor was removed?
If someone had a primary tumor removed or eradicated in the past and is now being seen for something else or just follow-up, you use a code from category Z85, personal history of malignant neoplasm, for the former site. Any current spread or metastasis discovered now would be coded as a current secondary cancer. For admissions specifically related to cancer therapy, managing complications, etc., the neoplasm is generally the principal diagnosis. But the specific sequencing for administering the therapy versus dealing with complications of therapy also has detailed guidelines. Ultimately, when actively treating or investigating the extent of a cancer, the primary or metastatic site that is the focus of that specific encounter is usually the principal diagnosis.
So the main reason for the encounter really dictates the sequencing of the codes in cancer cases. What about the difference between coding a current cancer versus just a history of one? When does it switch?
For a current cancer, you keep using the code for the primary or metastatic malignancy as long as the patient is receiving active treatment for that site.
Okay.
You switch to using a Z85 history clone only when the original cancer has been fully excised or eradicated, no further active treatment is being directed to that site, and there's no current evidence of any remaining malignancy at that site.
So truly gone and treatment finished for that site.
Exactly. Codes Z85.0 through Z85.85 are for specific former primary sites, while Z85.89 can be used for a history of either a former primary or secondary site if a more specific code isn't available.
What about leukemia or similar conditions?
For leukemia, lymphoma, and related conditions, there are specific codes to indicate if the disease is in remission. It's important to use these based on the provider's documentation, and you should query the provider if the remission status isn't clear. Z85.6 and Z85.79 are used for a personal history of these conditions once they are in remission or cured.
Okay. Any other special cancer coding situations?
Yeah, a few highlights include specific coding for cancers related to organ transplants, T86 transplant complication first, then C80.2 malignant neoplasm associated with transplant, then the specific cancer code, secondary malignancies of lymphoid tissue using codes from C81, C85 with a sixth character of 9 to indicate extranodal site, and a specific code for breast implant-associated anaplastic large cell lymphoma, C84.7a. Also, there's C80.0, disseminated malignant neoplasm, unspecified, used only when cancer has spread widely and the original primary or secondary sites aren't known, and C80.1, malignant neoplasm, unspecified site, which is rarely used for inpatients as the site is usually identifiable. And a reminder, symptoms from Chapter 18 shouldn't be used as the principal diagnosis if a related cancer diagnosis has been established.
That's a very detailed look at a complex area. Let's move to Chapter 4, endocrine, nutritional, and metabolic diseases, focusing on diabetes mellitus coding. Seems like another area with lots of combination codes.
Yes, diabetes coding heavily relies on combination codes that bundle together the type of diabetes, any affected body systems like kidney, eye, nerve, and any associated complications.
So one code can cover type and complication.
Often, yes. And you can use multiple diabetes codes from categories E08 through E13 during the same encounter if the patient has multiple complications. The sequencing of these codes depends on the main reason for the visit.
What are the main types coded?
There are codes for type 1 diabetes, type 2 diabetes, which is the default if the type isn't specified in the record, and secondary diabetes.
Secondary diabetes.
Yes, that's diabetes due to other causes. It's further broken down. EO8 is for diabetes due to an underlying condition, like cystic fibrosis. EO9 is for drug or chemical-induced diabetes, and E13 is for other specified types of secondary diabetes.
Okay. What about medications, like insulin?
How medication use is documented is important. If someone uses insulin, but the specific type of diabetes isn't documented, the guideline says to code it as type 2 diabetes by default.
Really? Even if they use insulin?
Yes, for coding defaults. And in that case, you'd also add a Z code, Z79.4, for long-term current use of insulin. Similarly, Z79.84 is for long-term oral hypoglycemics, and Z79.85 for long-term injectable non-insulin anti-diabetic drugs.
But only if it's long-term use.
Correct. Don't use Z79.4 if the insulin use is stated to be temporary, like just during an acute illness or surgery recovery.
Got it. What about pregnancy or insulin pumps?
For diabetes during pregnancy and gestational diabetes, you're directed to the Obstetrics Chapter Guidelines, Section IC-15. For insulin pump complications, like an underdose due to pump malfunction, you'd code T85.6, mechanical complication, as the principal diagnosis, followed by T38.3x6, underdosing of insulin, plus the patient's specific type of diabetes and any resulting complications like hyperglycemia. For an overdose from a pump malfunction, it's T85.6 first, then T38.3x1, poisoning by insulin, accidental, plus the diabetes type and hypoglycemia.
Okay, pump issue first, then the drug effect, then the diabetes.
Right. For secondary diabetes, EO8, EO9, E13, the coding depends on the underlying cause, with specific guidelines for situations like diabetes after pancreas removal, post-pancreatectomy diabetes, and drug-induced diabetes. The sequencing for these secondary diabetes codes should follow any instructions in the tabular list and be based on the relationship between the diabetes and its underlying cause.
So it's really about identifying the specific type of diabetes, any related problems or complications, and the medications being used, with the order guided by why the patient is being seen.
Exactly. Documentation is key.
Let's look at Chapter 5. Mental, behavioral, and neurodevelopmental disorders, and specifically pain disorders mentioned there.
Right. This chapter covers pain disorders that are primarily related to psychological factors. There are specific codes here. F45.41 is for somatoform pain disorder, which is considered exclusively psychological in origin.
Exclusively psychological.
Yes, and the guideline specifically says not to use this code with codes from category G89, pain, not elsewhere classified, which are for pain conditions generally considered to have a physical basis.
Okay, so F45.41 is separate from G89 pain codes. What's the other one?
The other is F45.42, pain disorder with related psychological factors. This code is used when psychological factors are judged to play a significant role in the onset, severity, or maintenance of pain, but the pain isn't considered purely psychological.
So this one could be used with G89.
Yes, this code can be used alongside G89 codes if the documentation supports both a physical pain component, acute or chronic, and significant contributing psychological factors. The key distinction is whether the pain is seen as solely psychological, F45.41, or if psychological factors are contributing to pain that likely has a physical basis as well, F45.42 plus G89.
That difference between pain being purely psychological versus having psychological contributing factors seems really key for correct coding here.
It is. It relies heavily on the provider's assessment and documentation.
What about substance use disorders? That's another area with, I imagine, a lot of specific detail.
Absolutely. Substance use disorders have specific codes to indicate remission status, early remission, sustained remission, or unspecified remission, 0.11, 0.21, 0.91, respectively. This coding is based entirely on the provider's documentation of remission.
Okay, and how does remission relate to abuse versus dependence?
Interestingly, the guidelines state that mild substance use disorders in remission are coded using the corresponding substance abuse in remission codes. Moderate or severe substance use disorders in remission are coded using the corresponding substance dependence in remission codes.
So mild use in remission, abuse in remission. Moderate severe use in remission, dependence in remission. Got it. What if someone uses multiple substances?
If multiple levels of use, abuse, and dependence for different substances are documented, there's a coding hierarchy. Dependence codes take precedence over abuse codes, and abuse codes take precedence over use codes for the same substance class.
Dependence abuse use.
Okay.
When do you use the unspecified use codes?
Unspecified use codes, like F10.9 for unspecified alcohol use, should only be assigned based on provider documentation of use, and typically only when that use is associated with a documented substance-related disorder, like withdrawal, or a medical condition clearly linked to the use. They aren't assigned just because someone reports drinking alcohol, for instance.
Right. What about medical problems caused by substance use?
For medical conditions that are due to substance use but aren't classified as specific substance-induced disorders themselves, like alcoholic pancreatitis, you code the medical condition first, followed by the code for the relevant substance use, abuse, or dependence. Example, for alcoholic pancreatitis due to alcohol dependence, you'd code K85.2, alcohol-induced acute pancreatitis, first, followed by F10.2, alcohol dependence, uncomplicated.
Okay, medical condition, then the substance disorder. What about blood alcohol level?
If a blood alcohol level, BAL, is documented, you can use an additional code from category Y90, evidence of alcohol involvement determined by blood alcohol level, along with the relevant F10 code for alcohol use, abuse, dependence. And the source of the BAL documentation isn't restricted to just the primary provider.
Good to know. And factitious disorder.
For factitious disorder, there are codes for factitious disorder imposed on self, F68.1, and factitious disorder imposed on another, also known as by proxy. For the by proxy situation, code F68A is assigned to the perpetrator's record, while codes from T74, confirmed abuse neglect, or T76, suspected abuse neglect, are assigned to the victim's record.
Okay. Any general rules for Chapter 5?
Generally, mental health disorders are classified based on etiology, cause, and severity, unspecified, mild, moderate, severe, according to the provider's documentation. For inpatients, if different severity levels are documented during the stay, you assign the code reflecting the highest severity documented.
So remission status, a clear priority for different levels of use, and specific codes for medical issues caused by substance use are important takeaways here. Let's look at Chapter 6, Diseases of the Nervous System, and specifically coding for dominant versus non-dominant sides and pain.
Right. For conditions like hemiplegia or monoplegia, paralysis, categories G81, G83, where the code requires specifying dominant or non-dominant side. If the documentation states the affected side but not the dominance, there are default rules.
Defaults.
Yes. If the patient is ambidextrous, the affected side is considered dominant. If the left side is affected, it's considered non-dominant. If the right side is affected, it's considered dominant. These are just defaults if dominance isn't specified.
Okay, helpful defaults. Now, pain coding using G89 codes, how do they work?
Codes from category G89, pain not elsewhere classified, are generally used to provide more detail about pain, often alongside other codes. However, the guidelines say you should not assign a G89 code if the documentation doesn't specify whether the pain is acute, chronic, post-thoracotomy, post-procedural, or neoplasm-related.
So you need that extra detail.
Yes.
Oh.
Also, don't use G89 if the underlying definitive diagnosis causing the pain is known, unless the specific reason for the encounter is pain control or pain management, rather than managing the underlying condition.
Ah, so the reason for the visit matters.
Very much. A G89 code can be the principal diagnosis when the main reason for admission or encounter is specifically pain control or management, or for a procedure like inserting a neurostimulator for pain relief.
Okay. What if you have both a G89 code and a site-specific pain code?
When using a G89 code along with a code that specifies the site of the pain, like low back pain M54.5, the sequencing depends on the purpose of the visit. If the encounter is primarily for treating or managing the pain, the G89 code comes first. If the encounter is for treating the underlying condition causing the pain, the site-specific code would typically come first, and the G89 code might be added for detail if appropriate.
Got it. What about postoperative pain?
For postoperative pain, if it's not specified as acute or chronic, it defaults to the acute code. Routine or expected postoperative pain immediately after surgery shouldn't generally be coded.
When do you code it?
If the postoperative pain seems unusual or is being specifically managed and there's no documented complication causing it, you use the appropriate G89 code for postoperative pain. If the pain is associated with a specific postoperative complication, like an infection, you code the complication first, using codes from Chapter 19 injury poisoning, and then add the G89 code if needed to specify the pain itself.
Okay, and chronic pain?
Chronic pain uses codes from subcategory G89.2. Whether pain is considered chronic is based on the provider's documentation. There isn't a strict time frame defined in the codes. Neoplasm-related pain, G89.3, is specifically for pain documented as being related to the cancer, metastasis, or tumor, regardless of whether it's acute or chronic.
Is chronic pain syndrome different?
Yes, chronic pain syndrome, coded to G89.0 central pain syndrome, or G89.4 chronic pain syndrome, is considered a distinct condition from just chronic pain and should only be coded if the provider specifically documents that diagnosis.
So, side dominance has default coding rules, and pain coding requires looking closely at the reason for the visit, the type of pain documented, and whether the underlying cause is known or being treated. Let's move to Chapter 16 through 18, starting with Chapter 16, Conditions Originating in the Perinatal Period. These codes have a very specific time frame, right?
Yes, the perinatal period is defined for coding as starting before birth and ending 28 days after birth. Codes from Chapter 16, P000-P96, apply to conditions originating in this period.
Key rules for these codes.
A big one. Chapter 16 codes should never be used on the maternal mother's record. And conversely, Chapter 15 obstetrics codes are never used on the newborn's record.
Okay, strict separation. Can they be used later in life?
Yes. Interestingly, a Chapter 16 code can be used throughout the life of the patient if the condition originated in the perinatal period and continues to affect them.
Gotcha. What's the main code for a newborn?
For the birth admission record, the principal diagnosis is usually a code from category Z38, live-born infants, according to place of birth and type of delivery. This Z38 code is used only once on the newborn's record at the time of birth. It's not used if the baby is transferred in, and it's never on the mother's record.
Z38 once at birth. Can Chapter 16 codes be used with other codes?
Yes, they can be used alongside codes from other chapters to provide more detail. If the reason for the encounter is specifically for a perinatal condition, the Chapter 16 code should be sequenced first.
What if it's unclear if a newborn's condition is perinatal or acquired later?
If the documentation doesn't specify, the default assumption for coding is that a condition noted in a newborn originated in the birth process, perinatal. You should not use a Chapter 16 code if the condition is clearly documented as being community acquired after birth.
Okay. What conditions get coded on a newborn's record?
You should code all clinically significant conditions noted on routine newborn examination. That means conditions requiring clinical evaluation, diagnostic procedures, therapeutic treatment, an extended length of hospital stay, increased nursing care, or those having implications for future healthcare needs.
So not just trivial findings. What about ruling things out?
Codes from category Z05, observation and evaluation of newborns for suspected conditions ruled out, are used for healthy newborns when a suspected condition is evaluated and then ruled out. These codes should not be used if the baby has signs or symptoms of the suspected condition. Z05 can be the principal diagnosis after the birth encounter, when Z38 no longer applies, for healthy newborns being observed, or it can be a secondary code after Z38 on the birth record.
Okay, prematurity, low birth weight.
For prematurity and fetal growth restriction, FGR, you only code prematurity if it's documented by the provider. Codes from P05, FGR, and P07, disorders related to short gestation and low birth weight, are used based on the documented birth weight and gestational age. If both are known, the code for birth weight should be sequenced before the code for gestational age.
Can those low birth weight codes be used later?
Yes. Codes from P07 for low birth weight or immaturity status can continue to be used beyond the perinatal period if the condition is still affecting the patient's health status.
What about sepsis in a newborn?
Bacterial sepsis of the newborn is coded to P36. This category includes congenital sepsis, which is the default if the type isn't specified.
And stillbirth.
Stillbirth is coded P95. This code is only used on separate stillbirth records, no other codes are assigned with it, and it's never used on the mother's record.
Okay. COVID-19 in a newborn.
For COVID-19 in a newborn, you assign USO 7.1 and codes for any associated manifestations. If the infection was thought to be contracted in utero or during the birth process, you'd code P35.8, other congenital viral diseases, followed by USO 7.1, with Z38 still being the principal diagnosis on the birth admission record.
Very specific rules for a very specific patient group. Let's look at Chapter 18. Symptoms, signs, and abnormal clinical and laboratory findings, not elsewhere classified. We touched on this, but let's highlight some key points again. When are symptom codes okay?
Symptom codes from Chapter 18 R codes are acceptable to use when a related definitive diagnosis hasn't been established or confirmed by the provider by the end of the encounter.
Can they be used with a diagnosis?
Yes, they can also be reported as additional codes if the symptom is not considered routinely associated or integral to the definitive diagnosis that has been established. But you should not code symptoms that are just a normal, expected part of the diagnosed condition.
Right, avoid redundancy.
Exactly. Some combination codes in other chapters already include both the diagnosis and common associated symptoms, so you wouldn't add a separate symptom code in those cases.
What about repeated falls?
For repeated falls, R29.6 is used when a patient is currently being investigated for the falls. Z91.81, history of falling, is used to indicate a past history or future risk, often when the patient isn't currently falling but is at risk. Both codes can be used together if applicable.
Okay, coma.
For coma, R40.20 unspecified coma is used when the cause is unknown or if it's related to trauma but the coma scale score isn't documented. You should not use these codes for medically induced comas. The specific coma scale codes, R40.21, R40.24, are used primarily with traumatic brain injury, TBI, often for trauma registries. They are sequenced after the diagnosis codes, and at least the initial score documented on presentation should be reported.
Gotcha. SIRS.
For SIRS, systemic inflammatory response syndrome, due to a non-infectious process, you code the underlying non-infectious condition first, followed by a code from R65.1, R65.10 without organ dysfunction, R65.1 with acute organ dysfunction. Then you add codes for any specific organ dysfunctions if documented. Remember, R65.2 is for severe sepsis, infectious.
Okay, different R65 codes for infectious versus non-infectious, death and OS.
Death NOs, not otherwise specified, code R99, is only for use in the rare instance when a patient who is already dead when they arrived at the facility, DOA, has no other diagnosis documented.
And the NIH stroke scale.
NIH stroke scale, NIHSS, score codes, R29.7, are used in conjunction with acute stroke codes, I60, I63. They're sequenced after the acute stroke diagnosis code, and similar to the coma scale, the initial score documented is typically reported.
So, symptom codes fill in the gaps when a diagnosis is missing or when a symptom is unusual or significant on its own, but they shouldn't replace a diagnosis or duplicate normal symptoms. Finally for this set, Chapter 19, Injury, Poisoning, and certain other consequences of external causes. The seventh character seems really important here.
Absolutely critical. Chapter 19 codes for injuries, poisonings, and certain other consequences often require a seventh character to indicate the phase of care for the condition.
What are the main ones?
A is for the initial encounter while the patient is receiving active treatment for the condition. D is for a subsequent encounter used after active treatment during the routine healing or recovery phase. And S is for sequela, used for complications or conditions that arise as a direct result of the injury long after the acute phase.
And it's about the phase of care, not the provider.
Exactly. The seventh character choice is based on whether the patient is undergoing active treatment, routine healing, or dealing with a late effect, not whether they are seeing a new or established provider for that condition. And importantly, don't use Z codes for aftercare following an injury or poisoning. You use the injury poisoning code with the D subsequent seventh character instead.
Okay. How do you code sequelae again?
For sequelae, late effects, coded in Chapter 19, you sequence the code for the sequela condition itself first, like contracture, scar, pain, followed by the original injury code with the S sequela seventh character added.
Got it. General injury coding rules.
For multiple injuries, use separate codes for each injury unless a specific combination code exists. Sequence the code for the most serious injury, as determined by the provider and the circumstances of treatment, as the principal diagnosis. Don't code superficial injuries, like abrasions or contusions, when they occur at the same site as a more severe injury, like a fracture or open wound.
Okay, most serious first. What about TO7?
TO7, unspecified multiple injuries, should rarely, if ever, be used for inpatient coding, as specific injuries can usually be identified.
What if an injury damages nerves or blood vessels?
If a primary injury, like a fracture or open wound, results in damage to nerves or blood vessels in the same area, you generally code the primary injury first, followed by code for the nerve and or vessel damage. The exception is if the primary injury is the injury to the nerve or vessel itself.
And injuries during medical care?
Injuries that occur during or as a result of a medical intervention, iatrogenic injuries, are generally coded as complications of care using codes from the body system chapters or specific complication codes like T codes, not as traumatic injury codes from Chapter 19.
Okay, fractures. Lots of detail there too.
Yes. Code each fracture individually by site unless a combination code exists. Unspecified fractures, where documentation doesn't state open, closed, or displaced and non-displaced, are generally defaulted to closed and displaced for coding.
7th characters for fractures.
Yes, very important. The 7th character for fractures indicates initial encounter for closed, A, initial for open, B, C, depending on type, subsequent encounter with routine healing, D, G, K, depending on type status, subsequent with delayed healing, E, H, M, subsequent with non-union, F, J, N, subsequent with malunion, P, Q, and sequela, S.
Wow, very specific.
Yes. Open fractures are also classified using the Gustilo classification system, types QA 2, 3, reflected in the 7th characters B and C. Remember, pathological fractures due to underlying disease like osteoporosis are coded differently, M80 category, not as traumatic fractures from Chapter 19, sequence multiple fractures based on severity, physial fractures, growth plate, and these specific codes identifying the type of physial fracture.
Okay, burns and corrosions.
Burns are from heat sources, thermal, electricity, radiation. Corrosions are from chemicals. Coding requires identifying the site, the depth, first-degree erythema, second-degree blistering, third-degree full thickness, and the extent percentage of body surface area.
Sequencing.
Sequence the code reflecting the highest degree of bound first when multiple degrees are present at the same site or different sites. For burns involving both internal and external sites, the circumstances of admission determine the principal diagnosis.
Highest degree first. Only code the highest if multiple degrees at one site.
Yes, if different degrees of burn exist at the same anatomical site, only assign the code for the highest degree recorded for that site. Non-healing burns or necrotic tissue in burned areas are still coded as acute burns using the appropriate burn code. Infected burns require an additional code for the infection.
Okay, code each site. Body surface area.
Yes, assign separate codes for each burn site. Avoid using T30, unspecified burn, unless absolutely necessary. The extent of burns is often documented as a percentage of total body surface area, TBSA, often using the rule of nines, and there are codes, T31, T32, to capture this percentage based on depth.
Sequelae and current burns. External cause.
For late effects, sequelae of burns or corrosions, use the S7th character. It is possible to code both a current burn and a sequela from a previous burn on the same encounter record if both exist. And critically, always include external cause codes with burns and corrosions to identify the source, intent, and place.
Always need the how and why for burns. What about adverse effects, poisoning, underdosing, and toxic effects? Sounds complex.
It involves careful reading of the T codes, T36, T65, and the table of drugs and chemicals. These T codes are often combination codes that include the substance and the intent: accidental, intentional, self-harm, assault, undetermined. Because intent is included, you generally don't need an additional external cause code from V0000Y99.
Don't code from the table.
Right, never code directly from the table of drugs and chemicals in the alphabetic index. Always refer back to the tabular list to verify the code and tone for instructions. If multiple drugs or substances are involved, code each one.
Okay, adverse effect.
An adverse effect occurs when a drug was correctly prescribed and properly administered. You code the nature of the adverse effect first, like rash, nausea, tachycardia, followed by the appropriate T code, T36, T50, for the drug with the 5th or 6th character 5-foot indicating adverse effect.
Poisoning.
Poisoning occurs due to an error in prescription or administration, an intentional overdose, taking a non-prescribed drug, or interactions between drugs and alcohol. You code the appropriate T code, T36, T50, first, using the character for the intent, accidental 1%, intentional self-harm 2-part, SALT 3, undetermined 4, followed by codes for all the resulting manifestations or conditions. Accidental intent is the default if intent isn't specified.
Underdosing?
Underdosing means taking less medication than prescribed by the provider. This is coded with the appropriate T code, T36, T50, using the 5th or 6th character 6/4 for underdosing. This code is never the principal diagnosis. You typically sequence the medical condition itself first, and you might also add codes for noncompliance, Z91.1, or complications resulting from the underdosing.
Toxic effect.
Toxic effects refer to harmful substances, chiefly non-medicinal, as to source that are ingested or contacted. Codes T51, T65. You code the toxic effect code first, followed by codes for manifestations. You also need to include an external cause code to specify the intent, accidental, self-harm, etc.
Okay, lots of nuances there based on intent and proper use, abuse and neglect.
For confirmed abuse or neglect, sequence the appropriate code from T74 first, followed by any related mental health or injury codes. Also add an external cause code to identify the cause from categories X92Y09 assault and a perpetrator code, Y07 if known.
What if it's only suspected?
For suspected cases, sequence a code from T76 first. Do not add external cause or perpetrator codes for suspected cases. If abuse or neglect is ruled out during an encounter, use code Z04.6, encounter for general psychiatric examination requested by authority, or similar, not a T76 code.
Got it. Complications of care, pain from devices, transplants.
Pain specifically documented as being due to a medical device, implant, or graft is coded using the appropriate T code for the complication, followed by a G89 code for the specific type of pain, acute or chronic. For transplant complications, category T86 codes identify complications affecting the function of the transplanted organ. Often, T86 is used along with another code for this specific complication. For example, kidney transplant with chronic kidney disease, CKD, you'd only use T86.1, kidney transplant complications, if the CKD is documented as being due to transplant rejection or failure. Some T codes for complications already include the external cause. For intraoperative and post-procedural complications not covered by T codes, you generally code the complication using codes from the specific body system chapter first, potentially followed by additional codes for more detail.
That was an incredibly thorough look at Chapter 19. Let's move to our final chapters, 20 and 21, External Causes of Morbidity and Z Codes.
Okay, Chapter 20 covers external causes, V000Y999. Key point. These codes are never the principal or first listed diagnosis.
What are they for then?
They're primarily for injury research and prevention. They capture the cause of the injury or health condition, the intent, unintentional self-harm, assault, the place where the event occurred, the activity the person was doing, and the person's status, like civilian, military.
Are they required?
Reporting is generally voluntary unless a specific payer or state mandate requires them. They are intended to be used as secondary codes with codes from A00-200-88.9 disease injuries and 0000Z99 Z codes to provide context about how an injury or health condition occurred.
Seventh character is here too?
Yes, many external cause codes require a seventh character, A for initial, D for subsequent, S for sequela. You should use the full range of codes to completely describe the cause, intent, place, activity, and status related to an event using multiple codes if needed.
Place, activity status.
Place of occurrence codes, Y92, describe the location where the event happened, usually assigned once at the initial encounter. Don't use Y92.9, unspecified place, if the place isn't stated. Activity codes, Y93, describe the patient's activity at the time of the event. Also usually assigned once at the initial encounter. Not used for poisonings, adverse effects, medical misadventures, or sequelae. Don't use Y93.9, unspecified activity, if not stated. External cause status codes, Y99, indicate the work status, each civilian activity, military activity, volunteer activity, at the time of the event. Assign once at the initial encounter. Don't use Y99.9, unspecified status if not stated.
Is there an order for these external cause codes?
Yes, there's a priority sequence of multiple apply. Child-adult abuse codes take priority, then terrorism codes, then cataclysmic event codes like earthquake, flood, then transport accident codes, then activity and status codes.
Okay. Abuse, terrorism specifics.
For confirmed child-adult abuse, use the appropriate assault external cause code, X902Y09, and the Y07 perpetrator code if known. If intent, accidental versus assault, for abuse is undetermined, code to undetermined intent only if documented as such. For sequelae of external causes, use the relevant external cause code with the S's seventh character. Never use a sequela external cause code with a related current injury code. For terrorism events, Y38 codes are used. If the event is confirmed by the FBI as terrorism, Y38 is the first listed external cause code. If suspected but not confirmed, code is assault.
Got it. Now, Chapter 21, Factors Influencing Health Status and Contact with Health Services. Z codes, Z000, Z99. These seem different.
They are. Z codes represent reasons for encounters other than a disease, injury, or external cause. They can be used in any healthcare setting and can be either a principal first listed diagnosis or a secondary diagnosis, depending on the circumstances. Importantly, they are not procedure codes. If a procedure was performed, you still need a separate procedure code.
What kinds of things do they cover?
A huge range. Categories include contact exposure, Z20 for contact exposure to communicable diseases. Z77 for contact exposure to other hazards used for suspected exposure can be first listed for testing or secondary to indicate risk. Inoculations, vaccinations, Z23 used when an inoculation is given prophylactically, usually secondary for routine checks.
Status codes.
Yes, status codes indicate that a patient has a specific status, like being a carrier of a disease, having an artificial opening or transplanted organ, or having sequelae of a past condition. They are informative but don't represent a current illness. You shouldn't use a status code if the diagnosis code itself already includes that status information. Examples: Z14 genetic carrier, Z15 genetic susceptibility, Z79 long-term drug therapy, Z94 transplanted organ status, Z99 dependence on enabling machines devices.
History code.
History codes Z80, Z92 indicate personal or family history of past conditions. They help explain risk factors or the need for screening or follow-up, used alongside follow-up or screening codes to explain why the service is needed.
Screening, observation, aftercare.
Yeah.
Follow-up.
Screening codes, Z11, Z13, Z36 prenatal, are for testing in apparently well individuals to detect disease early. Different from diagnostic tests for suspected conditions, can be first listed. Observation codes, Z03, Z05, are used when a suspected condition is ruled out after evaluation, not used if symptoms are present, primarily principal first listed. Aftercare codes, Z42, Z51, are for continued care during healing or recovery phase after acute treatment, or for long-term care like dialysis or chemo. Not for acute injury treatment, use injury code with D. Often first listed except for Z51.0 chemo and Z51.1 radiation, which follow the malignancy. Follow-up codes, Z08 for malignancy, Z09 for other conditions, Z39 postpartum, or for surveillance after treatment is completed, implies condition is fully treated, use with history codes for context.
Donor codes. Counseling.
Donor codes Z52 are for living individuals donating organs or tissues. Counseling codes cover a range: genetic, Z31.5, procreation, childbirth, childcare, Z31.6, Z32.2, Z32.3, abuse, Z sexual matters, Z70, other health advice like travel or immunization safety, transition from pediatric care, Z71, pre-birth pediatrician visit, Z76.81.
Obstetrics, reproductive, and newborn Z codes.
Yes. Key ones include Z34, encounter for supervision of normal first of the pregnancy, always first listed for routine prenatal visits, Z3A, weeks of gestation, Z37, outcome of delivery, secondary on mother's record only, not newborn. Also Z33, Z39, Z76.81 for newborns, Z76.1, foundling, Z0.1, routine child health exam, Z38, live-born infant principal at birth.
Routine exams.
Miscellaneous.
Routine and administrative exams, 000 general exam, 01 special investigations like I hear, 0 administrative exam like pre-employment, Z32.0 pregnancy test, miscellaneous, Z40 prophylactic organ removal, principal with risk factors, Z40.0 for malignancy risk cases, others Z28, Z91.A, Z91.83, Z38, Z40, Z42, Z52. Social determinants of health, special purpose codes.
Social determinants of health, SDOH codes, Z55, Z65, capture factors like education, employment, Z56, occupational exposures, Z57, environment, housing economic circumstances, Z59, social environment, Z60, upbringing issues, Z62, lack of support, Z63, psychosocial circumstances, Z64, Z65. These can be documented by providers or other clinician staff, even self-reported data if signed off by a clinician. Special purpose codes, U00, U85, include U07.0, vaping-related disorder, U07.1, COVID-19, U9.9, post-COVID-19 condition. The SDOH codes, like the Hurricane Z codes, help track broader societal impacts on health.
That was an incredible journey through the ICD-10-CM guidelines. We've covered so much ground, from the basic structure to the real nitty-gritty specifics of coding numerous conditions and situations across so many chapters.
We certainly have. The key insights, I think, really boil down to that dual structure, alphabetic index and tabular list always working together for accuracy. Right. The crucial need to code to the highest level of specificity documented, understanding those specific rules for different types of conditions, acute versus chronic, etiology versus manifestation, and the importance of correct sequencing.
Yeah, sequencing came up a lot.
It did. And we also saw how those Z codes and the external cause codes add vital context beyond just the medical diagnosis itself, helping us understand the bigger picture of why someone needed care or what factors are influencing their health.
So we hope you, our listener, now have a much clearer understanding of the logic and the sheer amount of detail packed into these medical codes. It's definitely more than just assigning a number.
Oh, absolutely.
It's a systematic way of classifying the complexities of healthcare, which, as we saw, has significant implications for how we understand health trends and allocate resources.
And this raises a really interesting point to maybe leave you with. Consider how these coding guidelines, beyond their administrative uses for billing and stats, actually contribute directly to public health surveillance. They allow us to track diseases, injuries, the effectiveness of interventions, even the impact of social factors on health outcomes across populations.
That's true.
So what further questions does this in-depth look spark for you about how all this medical data is organized, analyzed, and ultimately used to try and improve healthcare on a larger scale?
Definitely something to think about. If this exploration has piqued your interest in a particular area of medical coding, we encourage you to explore the specific sections of the guidelines we discussed today. Thanks for joining us for this deep dive.
Launchpad से शुरू करो टेस्ट CPC भी सिखाए सबको बड़ा impress